Simpson, Executive Director of Aging Together, and we are pleased to present Navigating the Stages of Senior Care. Aging Together developed this video and its accompanying notebook to assist you in figuring out what options you have when you're caring for someone with a chronic or long-term illness. We discuss inpatient rehab, skilled nursing facilities, nursing homes, assisted living and memory care, skilled home health, non-medical home care, palliative care, and hospice. We include information on who qualifies for each service, how to pay for it, and any limitations on those services. You can go to the section of the video you're interested in or watch the entire 90 minutes. The notebook is also set up in similar sections. Aging Together is a collaborative partnership among senior serving organizations in Virginia's northern Piedmont area. We operate through work groups or teams in each of our 5 counties to develop and provide education and training for older adults and their caregivers. As a nonprofit, we rely on donations to keep our programs going. Please visit our website, agingtogether.org, for our upcoming events, information and resources, and much more. And please call us if you're looking for a resource and don't know where to start. I'd like to give special thanks for this video to Norm Allen, American Woodmark Foundation, UVA Health South, the Orange County Aging Together team, and all our wonderful speakers. I hope this information helps you as you navigate your caregiving journey. Thanks for all you do.
Our first presenter is Dennis Flannery. Based at UVA, serves as one of 6 rehab liaisons that are embedded at customer sites and out in the community to manage the safe, smooth transition of patients to UVA Health South for acute inpatient rehab, okay? AIR, also known as IPR, inpatient rehab. So all the initials that we in government use, we hope we've spelled it out for you. We're not looking for just an initial success, but a rather complete one. A 30-plus year veteran of marketing and sales in 6 different sectors, most recently in healthcare and rehab. Dennis also has a marketing role and is providing strategic account management support at UVA and within the UVA health system. Trina, his bride of 15 years, is his mother's primary caregiver, so he knows whereof he speaks. And Dennis is the maintenance director of this 1-bed nursing home. So both are well immersed in senior care issues. They have one son, Alex, a junior at Virginia Tech, I'll forgive him that, and one 30-year-old yard ornament, also known as a horse, that would be Cody. Today he is serving as his boss's stunt double, Rand Southworth, who is taking a well-earned and thrice-delayed vacation. So without further ado, Dennis, you're on.
Thank you. You read it just as I wrote it.
You definitely need to raise that mic up.
Yeah, that's not going to stay here.
Sound man.
Sound body.
There you go. Got it.
How's that? All right?
Yeah.
As he said, we are involved in caregiving at home. I am also bringing up the rear of the boomer generation. So I have an interest in every presentation here today because at some point I'm probably going to need some of these services. So just as he recommended, I want to be prepared. And it was actually brought home lately. My wife and I have started to have what we call senior moments. I get an amen? Will you experience those? Yeah. As a matter of fact, I'll tell you a quick story. We were sitting on the couch Friday. She's caregiver for a 94-year-old woman. We have help, but she says that I don't get the best of her. And one Friday night, we're sitting there, and she said, "What would you like? I'd like to do something for you." And I said, "You had a long day, and it's been a long week." She goes, No, I really want to do something. Would you like something? I said, "I really would like a hot fudge brownie sundae." And I said, "If it's too much for you," I said, "I'll do it myself." I said, "But, the brownie has to be heated about 20 seconds, and I want vanilla bean ice cream, not regular vanilla. I want hot fudge sauce, and that, if you use about 4 ounces, it's about 25 seconds you heat it, and I don't want the whipped cream. I want peanuts and no cherry. Is that too much to ask?"
Yes.
And she said, No. She goes, "I'll do that." I said, "Okay." I said, "You sure?" She said, "Yes." So she disappeared into the kitchen. She was gone in an inordinate amount of time. And she came back with not a bowl, but a plate of perfectly prepared scrambled eggs, cheese, sausage, and fruit. And I said, dang it, honey. I said, you forgot the toast. So they say the mind is the first thing to go. So you'll have to remind me if I get off course. So please, I know we said save questions till the end, but if you don't understand something, I tend to talk fast. Please feel free to stop me. I work for a company in a sector that is known as Inpatient Rehab Facility, IRF, or Acute Inpatient Rehab. They mix and misuse the terms all the time. But basically, there's a hierarchy in healthcare. So you've got the acute setting, which is typically the hospital. Then you've got the next level down, which is either acute inpatient rehab, which is what we are, or long-term acute care for folks that need ventilator weaning, long-term care, but not a whole lot of therapy. Then you've got what they call subacute or SNF, skilled nursing facility, and then you've got home health and you've got hospice. And there's crossover and there's overlap because there should be, because you don't want gaps. But basically, there's a cost factor related from high to low in that same hierarchy. So the hospital is going to be the most expensive, and then least expensive might be home health, PT, nursing care, those types of things. And so consequently, Medicare, and insurance runs this business, we all know that. Medicare is the 800-pound gorilla that rules this business, okay? Commercial insurance follows their recommendations and then gets even more restrictive. And what they want you to be in is basically the lowest level possible of care that will get you where you need to be, whether it's nursing care, medical care, physical therapy, occupational therapy. They would like you to be in the lowest possible level. So as a patient or as an advocate for a patient, you really need to know what those levels represent, what the general cost factors are, and how to make sure that you get the best possible care. So oftentimes you're pushing to go up a level where Medicare or commercial wants to push you down or push you home. So in any event, acute inpatient rehab is going to be generally 3 times more expensive on a daily basis than a skilled nursing facility. And so consequently, Medicare and the commercial insurers that follow their lead, they want us to take only the most appropriate patients. Okay, there's 13, you don't need to know all this, but there's basically 13 diagnosis codes that most of my patients have to come from within those diagnosis codes, okay, about 60%. So sometimes we can take a patient outside of those diagnosis codes. And I'll give you an example, some of those strokes, traumatic brain injuries, spinal cord injuries, those are the kinds of patients that they would rather us take. Okay. Now, as a business partner, UVA would also rather us take the most appropriate patients. They would rather us not take a bed for a patient who has had a simple, not for the patient, simple heart surgery, but for instance, a coronary artery bypass graft now is a fairly simple surgery, and a lot of patients can go home, a few days after having it done. Some may spend a week in a rehab facility just to make sure that the wound doesn't get infected. But people can pretty much go home. It's just amazing what they can do. So in any event, we normally wouldn't take that type of patient. But if we have 50 out of 50 beds and we have 10 of them open and most of them are going to be the kind of patients that Medicare wants us to take, then we'll take that type of patient. So it adds to some confusion in the market, and it can add to some confusion with patients. And so what we try to do in the hospital, which is where we typically will talk to patients, is try to explain kind of the vagaries and explain, what needs to happen for you to qualify, okay? So first there's a diagnosis, all right, which can be a little bit muddy. Then there has to be a medical management component. So if you're relatively healthy and you just have a coronary artery bypass graft, you don't have, maybe it's a hereditary type of blockage that you had, you don't really have hypertension, you don't have diabetes, those kinds of things. It's not really the type of patient they want us to take, but it's not a full disqualifier. One of the most significant qualifications is you have to be able to tolerate 3 hours of therapy a day, okay? And the reason for that, and the reason this model works, and the reason it is more expensive on a daily basis than skilled nursing facilities, is the research shows that after we hit age 60, we're 3 days worth of deconditioning. Okay, so if you're only getting about an hour or 30 minutes in the hospital every 3 days, you're kind of treading water. If you're only, depending upon what you have going on, if you're only getting an hour a day in a facility and rehab. We have rehab nurses. The ratio of patients to nurses is narrower because we have to watch these things closely. We typically have sicker patients, okay? And in order to push those patients appropriately and not send them back to the hospital, we have to have those doctors to be looking at them much more frequently than in other facilities. But then you're allowed, then you can get that 3 hours a day. All right. Now, it's not 3 hours on a treadmill. I couldn't do that. All right. The typical day starts about 7 o'clock. They come in, they wake you up, they give you your medicine, get a cup of coffee, maybe eat your breakfast, go to the bathroom, wash your face, comb your hair, get dressed. That's all occupational therapy. Okay, and typically you're going to need to split those hours between PT and OT. All right? Then the rest of the day they're going to intersperse it with some physical therapy. So most people, unless they're really debilitated, have spent a long time in the hospital or just have a whole lot of what we call comorbidities going on, comorbidities, can actually tolerate that, or you can work up to that level. If you also need speech therapy, if you have cognitive deficits because of a stroke, because of neurologic damage, then it's much easier to fit 3 hours amongst all those 3 different therapies. So to qualify, you have to have insurance. You have to have Medicare, you have to have commercial insurance. Commercial insurance has to say, yep, you can bring them in. Medicare wants us to make sure that you fall within the 13 most important diagnosis codes in their view. You have to have a medical management component. You have to be able to do 3 hours a day in therapy. So that's what gets you in. Generally speaking, average length of stay at acute inpatient rehab is going to be about 15 days in the state of Virginia, and that changes. Average length of stay in a nursing home, last time I checked, and I worked for Louisa Health and Rehab, run about 27 days. So we can generally get you home in about half the time. Commercial insurance and Medicare both want you to complete your therapy at home, which is a nice way of saying you're going to go home before you're not quite perfect. So you have to have somebody that can assist you at home because you're probably going to go home with a rolling walker or something similar, and you're going to need some assistance probably 24/7. Okay? Those are the basics. There's a lot of nuances. We work pretty intensively with the clinicians in the hospitals to make sure that they're using the right verbiage that will get you in, okay? If you have a cabbage, for instance, and you're on the pump too long and you get what they call cabbage head or encephalopathy, encephalopathy will qualify you for acute inpatient rehab. But if it clears, then you don't qualify. So if we bring you over at the point that you have some encephalopathy, it is a qualifying stay. It doesn't really cause you, it's not like you're going to get hit with a bill or anything, but we have to make sure that you are qualifying at the point we bring you in. So there's a lot of different, like I said, I guess vagaries is a good word, that apply. The best thing to do is make sure that you get good information up front, even if you can, before you go in for an elective surgery. But at the time you go into the hospital, the time to be talking to the case managers, the inpatient rehab folks, the nursing home folks, is the day that you get there. Make sense? I put you to sleep?
It only leads to lots more questions.
Yes. Thank you.
Our next presenter is Kristen Smith, and she is admissions coordinator for Dogwood Village, which many people in Orange County especially are familiar with. She has worked in the industry for 12 years and has spent her time assisting patients and their families with the transition to skilled nursing and long-term care from the community. Ms. Smith graduated from Christopher Newport University in 2005 with a degree in social work and spent the first 4 years at Dogwood as a social worker before transitioning to admissions. Kristen has evolved in local community coalitions, including CRH, UVA, MJH, to help reduce hospital readmissions and patient transitions. In her spare time, she enjoys spending time with her family and friends here in Orange County. Please welcome Kristen Smith. Try that, see how that works.
Good thing that adjusts pretty easily, huh, for the short people. Well, thank you for having me. Excuse my nasally voice. My allergies are trying to get the best of me, as I'm sure probably half of you. As he said, I work at Dogwood Village doing admissions. My primary focus is the health and rehab side, skilled nursing and long-term care. So I'm going to take the next 10 minutes to just kind of give you a quick overview of the difference between skilled and long-term. Much like acute rehab, we have a couple of initials that people kind of use simultaneously, but they do mean different things. So I'm going to just follow the outline that's in your packet, so that way it's easy to keep up with me. But first I'll talk about skilled nursing. So like Dennis said, you have to qualify for certain things. Skilled nursing, a lot of people talk about skilled nursing thinking they're talking about long-term care. When I talk about skilled nursing, I'm talking about short-term rehab. So, you have to qualify for Medicare to pay. And so it's not a certain diagnosis. We don't go by diagnosis. A lot of it's just kind of you've had an inpatient 3-night hospital stay, which is required for Medicare to pay. If you have a commercial insurance, that you don't have to have that inpatient 3-night stay. I'm sure if you've had a loved one in the hospital, you're seeing more and more observation stays, which if you are under observation, unfortunately, you will not qualify for skilled rehab if you have Medicare. Again, with commercial insurances, that doesn't really make a difference because you have to have authorization typically with your commercial insurance in order to come to a skilled nursing facility. So you have to have your 3-night hospital stay. The hospital, HealthSouth, they would refer to us to see if we feel like we could meet the needs. We would check your insurance prior to you coming to make sure, there's no glitches with that. And it's a 100-day Medicare benefit. So you have up to 100 days in a skilled nursing facility that your Medicare and your supplemental insurance will help cover as long as you meet qualifications. So like any insurance, just because you have 100 days doesn't mean you use them. Medicare looks at all of that to make sure you meet the qualifications, and as does the commercial insurance. So if you have a commercial insurance, such as Anthem or Humana is a pretty popular one, you have to typically get weekly updates sent to that insurance company for them to continue to authorize you to be there. So Medicare will pay for the first 20 days at 100%. Day 21 up to day 100, if you have a supplemental insurance, that would kick in most of the time. Again, we'll check that so you know what your benefit is. But if you do not have a supplemental insurance, there is a copay of $164.50 every day, starting on day 21. So it adds up very quickly. Like everything, there's different plans out there, so I do encourage you to know what your plan says because a lot of people don't. It's one of those things you don't really know until you need to know. So we do check that as a benefit to the patient and the family. But of course, at the end of the day, a lot of people do get shocked by what their insurance will actually cover. So as I said, private insurance does require the authorization. So what do we provide in skilled nursing? So we provide physical therapy, occupational therapy, and speech therapy. There is not a time limit, although we do encourage you to do as much as you can. We certainly, the goal is to get home. So that's, what we want to do. And again, Medicare hasn't really set guidelines and time limits on things. However, I can foresee that happening because the way the insurance companies are going, you're only going to get a certain amount of reimbursement for a certain diagnosis. So the quicker you can get home to the next, like he was saying, the lower level of care, the better. So we can also do IVs. So if you need an IV medication, if you need wound care, If you have a feeding tube, say you have a stroke and you can no longer swallow, so you have a feeding tube placed, we can do feeding tubes. Depending on the skilled nursing facility, each facility will do different things. So that's another thing when you're hunting, you may want to check to see exactly what they can do. Some do wound vacs, some do tracheostomy care, some can even, they're starting to do peritoneal dialysis there in the facility. So you really need to do your research depending on what you need to find the best level of care. Again, the goal with skilled nursing is short-term rehab. So it's not designed to be a long-term plan. It's just another level of care to get you home as quickly as you can. We have social workers at the skilled nursing facilities to help with all discharge planning needs. And then we work with a lot of the local home health agencies or personal care agencies that you'll hear from today to kind of transition that level of care from skilled to home. So then you also have long-term care. So what is long-term care? A lot of you refer to it as nursing home. Again, some people consider it skilled nursing. But it's when the patient's needs can no longer be met at home and they need to be in a long-term care facility. It's known as custodial care, and it does not require a hospitalization stay. So if you have a loved one at home and needs, maybe you have personal care coming in, then you can then bring a resident in for an evaluation to see if they meet long-term care. Medicare does not pay for long-term care, unfortunately. Medicaid will, but you have to qualify for Medicaid, and it's based off of your resources. You would apply at the local social services in the county that you reside. And if you are at home, it requires what's called a screening or a UAI, a uniform assessment instrument, to basically say that you meet the nursing home criteria. Private pay is also accepted. And so a couple of different payers, more so than the short-term rehab, are accepted. So if you do qualify, just quickly on Medicaid, if you do qualify for long-term care and you pass the screening in order to get into the facility under Medicaid, what they look at is your income, and they would determine what your patient pay to the facility would be. Social services would notify you of all of that, that each facility you would have the same patient pay. It's not facility specific. And then again, you want long-term care insurance is something that is pretty popular these days. You may get phone calls or flyers in the mail, them trying to sell long-term care insurance, and we do accept that as well. You just, again, want to check your individual policy, because some of them have elimination periods where they won't pay anything. You have to be in there for, let's say, 90 days before they'll start to kick in. And they also have maximum amounts, so they may only pay for 2 years. And then after the end, that policy is no longer valid. So typically the reasons we see people come in is because they've had like an acute change. So say they have a hospitalization and then they can't return home and they need long-term care after the skilled rehab. Maybe they've been managing at home, but it's just the caregiver, maybe they lose their caregiver. Their caregiver moves on or can no longer manage their needs. And sometimes we do have patients that come in on their own that they want to make the move because they don't want to be a burden to their family. So where I would encourage you to start is to do your research. That you can go to Medicare.gov and you can research each facility in the area. Go on a tour. Appointments are nice, but if you don't have time and you want to stop by, that's great too, because then you get to really see what's going on in the facility. So go at lunchtime, go at an activity time so you can see what's happening and what they have to offer. And then just talk to people in the community. You know, word of mouth says a lot. A lot of people in the Orange area specifically, you know, they've had a loved one somewhere, or they have heard this about it, or they personally stayed in the skilled facility. So word of mouth is always a good indicator. You know, it's a lot of times all the marketing in the world won't do what word of mouth will do. So I would encourage you to visit the facilities. And then application process is typically fairly simple. Apply through an application, and then a lot of facilities require a history and physical as well. And I'm getting, my time is up. So, but I'll be at a table. Ask me any questions, and thank you.
All right, our next speaker is Lisa Dodson, and she is the Marketing Director at Grace Retirement Village in Standardsville, Virginia. As a senior living consultant, you can see that she's living, Lisa guides seniors through the sometimes difficult task of understanding senior living options in Virginia. Sometimes? Only sometimes? Most of the time. These options include independent living, assisted living, skilled nursing, and memory care. Lisa is passionate about helping our greatest generation and their families make the right decisions to meet individual needs and enhance each resident's quality of life. Lisa?
Well, when we begin to look at assisted living, it certainly doesn't get any less complex. I can start by telling you that. I'm sure, like myself, as you drive down the road, as you go to the grocery store, maybe visit friends, you see the construction that's underway today in 55 and older communities. And for someone who's considering leaving their home and moving into an assisted living facility, it can be quite complex. And so most of my time is spent as a consultant really helping people to better understand the options that they have that are out there today for assisted living. I am going to speak today about two types of assisted living, just straight assisted living, what's available out there in the community, and then I'm going to speak briefly about memory care assisted living that's available as well. So what's happened over the last 10 or 15 years is that the acuity, people are living longer, and the acuity level at all of our facilities has gone up. So what you see today, the hospitals tend to want to discharge sooner because insurances don't want to pay for a long length of stay at a hospital. And so people go to a skilled nursing facility with different diagnosis that is much more acute than ever before. And then many times from a skilled nursing facility, they need to transition into assisted living. So over the past few years, things have changed in what an assisted living looks like, and that's what I'm going to share with you today. So today, assisted living certainly help with personal care. They provide socialization that sometimes people in the home do not have because they're living by themselves or because perhaps they have a single caregiver coming in. Medication management is probably one of the biggest things because of the number of medications that most of us take today. How many people here in this room take more than 2 medications a day? Lift your hand up for me. There you go. Lots and lots of people today taking multiple medications. Housekeeping, and then also food preparation. But some of the things you probably don't know is that in assisted livings today, we have physicians that come into the facility to care for our residents. We have a director of nursing who is there for oversight and care for our residents. We have staff nurses that are there, med technicians. We have physical therapists and occupational therapists, and that comes through relationships that we have in the community with partners who provide those services, and they can do that right on site. We have activity directors whose responsibility is to to plan the day and schedule different activities on-site and off-site for folks that live in assisted living. And we have pharmacy services that are available today. So no longer does a loved one or do you have to manage your pharmacy needs. Those are all done by the facility. So assisted living today in Virginia can look different based on the ownership of the organization and can offer different services. It can look different in that the way the physical building looks. Certainly you can enter an assisted living that may look more like a hotel, or you can enter assisted livings today that look more like a bed and breakfast kind of an environment. You need to think about prior to going to visit facilities. What would be most appropriate for me or my loved one? How do I think they would be what do I think they might be looking for, and where would they be most comfortable? What type of a facility? The other type of assisted living that is available today is memory care. And so memory care is offered to people today that are cognitively impaired, people that have dementia, or people that have Alzheimer's. And we are seeing today in our society more and more people who have Alzheimer's and dementia and who are living longer, right? And so those types of facilities, many of those types of facilities are offered today in Virginia. And the way that you look at an individual and determine that they may need memory care assisted living is that they may be exit seeking, they may be wandering, they may be up at night, they may have behaviors. And so if you're dealing with any of those types of things, you may want to speak to someone at an assisted living memory care facility. There are quite a few that are available out there today, very good memory care facilities available in Virginia today. So questions that I ask when someone comes into our facility, when I sit and help them, is I ask what is the individual that's looking for a placement, what are they actually able to do? You know, can they bathe themselves? Can they groom themselves? Can they dress? Can they toilet themselves? Those are some of the questions that I'm asking. And when you talk to a healthcare professional, those are called activities of daily living. And we also sometimes say ADLs. And that can be very confusing when we use that verbiage. But what we're really asking is, from a personal care standpoint, what can this individual do? The other things that I'm asking about are medication management, food preparation, housekeeping, and laundry. So when you're thinking about assisted living, what you want to do is ask yourself those same questions. You know, where are we in all of this? What are the things that I can do that I'm struggling with? And make a list of those things prior to visiting a facility. And I've heard multiple people here today talk about how important it is to visit. And it is really important to visit and to be prepared to visit so that you can ask the right questions. I'm going to take that information, every consultant here is going to take that type of information, and we're going to try and help determine what level of care is most appropriate for you. Honestly, Christian just spoke about a nursing home. It may be that the level of care that is needed for that individual is not assisted living. It could be that it needs to be a higher level, which is going to be more of a nursing home. It could be that it's an Alzheimer's patient, but because of the level of care that they need, they may need to be in a nursing home that offers a secured Alzheimer's and dementia unit. And we're seeing that more and more today. So know that. There's also something called continuing care retirement communities. And that's a community where they offer multi-level care so that as the individual ages, they can move into another level of care. So consider that as well and ask those questions when you go to visit. Again, it's important to tour. It's important to be prepped when you go and tour and have your questions, understand what your needs are, and have your questions written down so that you can ask the appropriate questions. We are regulated at the state level. Assisted livings are by the Department of Social Services. And when they come in to monitor, they typically do that every year or every couple of years. They're looking at the care that's provided. They're looking at outside assistance, the providers that are coming in. They're looking at the food service, foods that are prepared there, and they're looking at the safety of the residents. And people call me all the time and they say to me, Lisa, I need to have some idea of cost. So I did some research online and I considered some of the facilities that are here locally, and on average it starts at about $3,000 to $3,500 and goes up in Virginia for assisted living. It's typically private pay. There are some Medicaid benefits that are available, but people come to me and they typically use their Social Security, they use retirement, they use long-term care insurance. Kristen spoke about that. They will perhaps take out a mortgage on their house sometimes, a second mortgage. There's companies that will have that offer those services. Life insurance. Sometimes life insurance can be that you can take out loans against long-term life insurance. And sometimes people come to me because they're in a spin-down situation looking to move to Medicaid. So they have X amount of money that they need to spend before they're going to qualify, as Kristen spoke, and be able to get Medicaid. In your packet, I could talk for I usually on a typical consult, honestly, I spend about 2 hours with a family. That's how long it takes to talk through the process of what's out there and available and what they actually need. I have put on the back table for you a checklist for your activities of daily living so that you can go ahead and note what services you're going to need. I have also put a questions to ask on your visit. There is also a veterans benefit called Aid and Attendance. There is some information about that on the back table as well. Thank you so much.
Our next presenter is Diana Bright. She has a master's degree in gerontology and an undergraduate degree in healthcare administration. She is a certified dementia practitioner and certified TIPA SNO positive approach to care trainer. Her professional background is in recreational therapy, nursing home administration, education, and currently as an account liaison for Encompass Home Health. Helping people and changing the culture of dementia care is Diana's passion. Please welcome her.
All right, well, good morning, everybody. I'm going to try to speak with less information. I'm following a lot of great presenters, and you've already received a lot of great information. As you heard Bob present in my bio, I've held a variety of different roles in the long-term care healthcare sector. So I can see different sides and how home care services can be beneficial and how we all work together. So what we have learned is that insurance and hospitalization in the healthcare field is really changing. What is everyone's goal in this room as we age? To stay home. When I worked in assisted living, I would always say that no one's dream is to move into a long-term care facility. However, it's very important that you're here to get this information so that you are prepared if you have to make that decision. So, what is home health care? Home health care is a skilled benefit that provides in-home services, but is different than private pay home care services. We do have another representative that's going to speak about that. That seems to be the number one misconception, is that skilled home health services is not 24-hour services 7 days a week. The way that it works is that we provide skilled nursing, physical therapy, occupational therapy, or speech therapy services in the home on average of 3 times per week, depending on the needs. So how is this initiated? You can receive home health service hospitalization. That does not require a minimum night stay in the hospital. You can receive, most commonly, home health services after you complete a stay in a skilled nursing facility or an acute rehab setting. How is home health services paid for? Typically through Medicare or private insurance. There is a 60-day certification period, so if you are qualified to be appropriate and have a need for home health services, the cert period will be 60 days, and then after the 60 days they will reevaluate. So there's no minimum or maximum time frame for the amount of in-home services that you can have. A change that we're seeing in home health is that people are trying to be more proactive instead of reactive. So you do not have to have a stay in the hospital or to go to a long-term care skilled nursing facility to have home health. You just have to have an order from your physician. So if you know of someone or if you are providing services to a loved one in the home and you're not really ready for the long-term care placement, home health may be an option to help you keep that person at home a little bit longer. All right, so some things that the different disciplines cover. Skilled nursing, a common example is if someone were to have a wound. Physical therapy, occupational therapy. We do offer social work services that kind of can help guide you through the continuum and let you know what resources and services are out there for you. So that is all I'm going to say about home health.
Next up is Jenna Mullins, and she is the Community Liaison for Home Instead Senior Care, a leader in the home care industry who works to support seniors and their desire to live healthy, independent lives at home. As a healthcare professional for 20-plus years, Jenna attended Mount Aloysius, am I pronouncing that correctly? Thank you. Aloysius, thank you. PA, and is a Dale Carnegie graduate. A Culpeper County resident for 25 years, Jenna is active in her community. Indeed, Jenna and I met through her work with SAFE and my work with social services. Jenna is an advocate for local seniors, serving as secretary of the Page Triad SALT Committee for the past 3 years, an active member of the Orange County Triad SALT Committee, Aging Together Committee, and Tri-County Alzheimer's Walk Committee chair for 3 years. Jenna is also a recipient of the 2013 Culpeper Town Police Community Service Award. In her spare time, Jenna enjoys spending time with her family, gardening, and if pressed, will own that she is a Pittsburgh Steelers fan.
Not since Sunday.
Not since Sunday.
Good morning, everyone. And we're really happy that so many of you came out. This is an opportunity for you to learn not only about what your needs are, but what else is available in your community. So you've heard a lot of information this morning about hospital care, skilled care, home health, and I'm here to talk about home care, in-home care. So how does that differ from home care, from the home health? It's non-skilled. That means that you're dealing with your activities of daily living, whether it's brushing your teeth, dressing, needing assistance with bathing. Those are activities of daily living that we all sometimes take for granted, but at some portion of our life we're going to need assistance with. So in-home care typically has 2 levels of care. It can be called home care. It can be called non-skilled care. It can be called companion care. But typically, there's two types of care. The lowest level of care is your home helper or your companion care. And that includes anything from dressing, medication management, or reminders. It can be meal preparation. It can be bathing. It can be companionship. It can be providing transportation to the grocery store, to doctor appointments. In addition to that, then you have the personal care side. And in Virginia, personal care is defined as when a person can no longer handle their private areas themselves. So when it gets to that level of care, then you need trained, qualified personnel to help you with that. Now, unfortunately, in Virginia, you don't have to have a license to be a caregiver. So there are many agencies out there that aren't licensed. So that's one thing that I do ask you to do your due diligence when you are looking at home care to see whether or not they're licensed. Home care agencies are, if you are licensed, they are licensed through the Department of Health out of Richmond. So that means that they may not only be inspected and audited through their corporate companies, but they are audited and inspected through the Department of Health out of Richmond. So that's important to know, okay? Some other things that you want to be aware of when you're dealing with home care agencies, you want to see if they do background checks, criminal background checks. Do they do the county? Do they do the state? And do they go one step further and do the federal, which is the national one? Because guess what? If you're new to Virginia and you only do the county or the state criminal background check, that's all the information that you get. You get nothing from when they were in Pennsylvania, Delaware, out west. So that's important to know who you're dealing with. Do the agencies do drug and alcohol testing? Not only when they first come on board, they're caregivers, but do they do random testing? Lifestyles change, things happen. You have to stay ahead of the game. And then do they bond and insure their caregivers so that you feel comfortable bringing someone into the home that you may or may not know? Also, what kind of training do they receive? Do they receive 2 days of orientation and then they get no other training? Do they do monthly trainings? Do they do in-services? Who trains their staff? Is it by an RN? Is it by just the administrator who may not have a health care background? You need to be aware of these things. So in your booklet, under home care section, you'll find a list of questions that you really should take a look at when you're looking at home care services. And some of those questions are just some of the same things that I've just gone over with you, but there's an entire list. The second part I want to talk about is personal care. And personal care is that higher level of care that sometimes we need. As you've heard from several of our previous speakers, no one wants to see themselves go into a facility. So you can receive 24/7 care by a in-home care agency, but it's going to cost you, okay? There is a list of options, payment options, anything from long-term care insurance, which you've heard Kristen talk about, and several others, and long-term care insurance. They are so individualized nowadays. About 25 years ago, there may have been 3 or 4 policies out there. Now, they're individualized to the person when you purchase that policy. So you could have a 90-day wait period before your benefits kick in, or they could start from day one. You want to know that whenever you're looking at your policy. What does my policy cover? Does it have a limitation? As some policies will only pay up to 2 years. Some of the very old policies, after you reach a certain age, they stop asking for you to pay into it, and you don't have a maximum amount. They take care of you until you die. Those policies don't exist anymore. Those were the very old grandfather policies. Okay? So if you have those types of policies, don't wait to use them. That's another thing that we find, that people have insurance and they're not utilizing it. They wait until they get into a crisis situation before they start looking, and then they have to move very quickly because you're in crisis mode. So do your due diligence, just like you're doing here today. You're finding out what all the options are. So personal care is everything that I went over with home helper care, but it also includes incontinent care. If you're having accidents or a family member starting to have accidents and they don't allow you as the family member to help them, sometimes it's easier for an outsider to come in and assist. They can also help with bathing, especially if dementia is involved or Alzheimer's. And for those of you who aren't familiar with dementia, dementia is like a huge umbrella. And all of these different levels of dementia fall underneath that. And Alzheimer's happens to be the most prominent one that people, I think, identify with. But there's over 100 different types of dementia out there. So you want to know, who can help you. Is the home agency that you're hiring or that home care person able to work with my mom, my dad, my grandparent, my significant other? Do they understand that they have significant needs that even sometimes I can't get through to? I want to give you for instance, if you're having difficulty with someone bathing, you have to think outside the box sometimes. That person, that gentleman who was your spouse, was in the military for 30 plus years, came out as an officer and won't take a shower. So how do you get that person to take a shower? Think outside the box. That person was in the military, so what do they know? They remember military life. So you go up to that person and you say, "Sir, it's time to inspect the troops later today. So you'll need to get a shower." And guess what? It's much easier to lead that person into the shower. You just have to think outside the box sometimes. There are ways of handling certain situations, and you want someone who's trained, who knows about behaviors, who knows about redirecting. The Alzheimer's Association has a lot of information out there online, both online and locally. And there are a lot of opportunities for you all to attend seminars over at Culpeper Library, as well as at the Tech Center. And next year, Teepa Snow's coming back. And for those of you who don't know anything about Teepa Snow, you want to look her up online. She's an amazing person who has dealt with Alzheimer's and different types of dementia, and you can learn a lot in a short period of time. So the different home care payment options. Unfortunately, Medicare will not pay for this. Private insurance, we're finding more and more, if you've worked for a major corporation, if you've been in the military, they don't call it long-term care insurance. However, they will carve out a benefit package for you. And I will tell you that personally, 3 out of the last 6 clients that we brought on board didn't even know they had that benefit package. It were family members. I told them to just check on it. It doesn't hurt to check. Many times teacher organizations, if you were a teacher for 30 plus years, they didn't call it long-term care insurance, but they can carve a small package out for you so that you can at least have some help in the home until you're ready to make that next step to transition into either assisted living or a facility. Another option is if you were in the military and you served at least 1 day during wartime, there is the Home Helper or the Homemaker Home Helper Aid Program. This is the only veterans benefit program that is based on need and not finances. You must be in the VA system and you must have a written order from a physician in the Veterans Administration to receive in-home care. Typically, it's not a lot of hours, anywhere from typically 4 to maybe 10 hours a week. Most cases, when someone is home and they're bedridden, they may get 15 up to 30 hours. But typically, it's the lower end. Another means of payment is Medicaid. And I think Kristen did an excellent job explaining about Medicaid so that you know how to file for that. It's the same for in-home care. There's also a portion called the Medicaid waiver, and that allows for a little bit higher income if you're seeking assistance in the home. So you may want to check that out. And then last but not least, you've got private pay. And I can't stress enough, you're from a generation where you were taught to save. Unfortunately, our generation nowadays, it's self-gratification. So they're not saving. So it's important to take a look at your finances now, before something happens. If you own a home, what's your best option? Do you sell the home? Do you move into an assisted living? Do you get home care from an in-home agency to help you until you can transition into an assisted living or into a long-term care facility? I applaud you all for coming here today because this is very, daunting to a lot of people. And until they have to experience it, everyone's in crisis mode, and that just irritates everyone. You're so excited. You're overwhelmed, and this is an opportunity for you to take a look step by step. Where am I at in life? What do I think I may need? And if I need that, what am I going to look at? So do your due diligence, take a look at everything available in your community, take a look at things that might be outside the box. And if you're moving into an area where your relatives are located, make sure you do your due diligence and check their ratings both online and their state licensure so that you know what they've done in the past, where they're at now, and are you going to feel comfortable there. I thank you again for having us. This has been a great opportunity for you all, but also for us, because quite honestly, I've learned a little bit today too that I haven't. And I've been in the healthcare industry for a long time. So thank you very much. Appreciate it.